we want to sit in just for fun.
Yeah.
Yeah, just want to sit down. I was like,
This morning I was like, it's been a long time since I've seen my friends. And I was like, wait, it was Monday.
it was Friday, Thursday.
This is a long time. So I'm like, next time.
Hey, Christy.
Yes.
For practicum in the fall, is it the same thing where we'll have clinical one day and then do we still have learning lab?
Yep, you'll have clinical one day, you'll have learning lab one day, and you'll have 4 steps.
So
What
then,
day the learning lab usually is? or no?
Tuesday and Wednesday.
so then for
Just like now.
second year, do we, is it like we'll have class a day and then do we have, how much clinical days do we have?
You have 1 clinical day, you have a couple of sim days, and you'll have learning lab right at the beginning of the semester, for the first 2 or 3 weeks.
Okay, and then we have a class the one day a week?
1 day a week.
Okay.
So I just had a student in Chanute, and she was there all day, every day, because like.
They
of a
do
class.
a different schedule.
Oh, okay.
They
She
do
was there like all day, every day.
Yeah, they do a different schedule, so there, it depends. See, in second level, but you shouldn't be worrying about this now. In second level, PCC will meet, and it's always on Tuesdays here. PCC meets from 9 to 12, and then every other week you will have PNC because it's only a 1 credit hour course. So it'll be from 1 to 3 every other Tuesday afternoon. So anyway, but
But then learning lab is also Tuesday and Wednesday?
not for second level. Second semester.
Oh, okay.
Yeah, yes.
Okay, we're not worried, we were just asking.
Yeah,
So-
yeah.
Yeah, okay.
And I don't do second level.
Right.
You don't?
No.
Nothing?
Yeah, well, I teach.
Oh, okay.
But
It's not like
not-
you're.
you
I don't
practice.
do practicum,
Yeah,
and I don't usually coordinate the courses.
Okay, thanks, Chrissy.
Can I put you in charge? There's a sign-up sheet, a sign-in sheet, just put your initials by it, please. Sure, everybody here knows that.
Yeah, it's due in June.
No, cognition prep view is already closed.
I thought it was due the first. It was due yesterday.
Oh my God.
Oh, okay.
I feel like. You feel like what?
It said 8 or 11.
No, they always say 8.
Or 8 p.m. They do 12 a.m.
She comes up to 7.
Just initial it, pass it around.
I went to the first day, I did forever ago, and she said, "Oh, you do it, she'd give me credit, and I did it, and she never gave me credit."
Well, you know my grade. I forgot one. I was grade for
And assessment?
whatever that class was for homework. Because I'm curious what 20 points is going to do.
I don't know, I'm still an A.
Mine, I completed, and I missed one, numbers.
So is the owner of this beautiful stethoscope here?
yes, oh my gosh,
How many times are you gonna leave that laying around?
I know, it's so bad.
It's not, I don't think it's yours.
No, it's mine.
It was left on Tuesday.
Oh, so it's not
Oh.
yours.
It's not yours.
It looks the exact same though, but I was like, how do you leave yours? Where is your stethoscope then?
This was left Tuesday morning after.
You have yours? Okay.
She and I have already had a discussion, so I know it's hers.
I'm pretty sure I do. I'm pretty sure.
I saw that email and I was.
I'm sorry.
Yeah.
All right, if you can't hear me, just,
Throw something at the wall.
come in and tell me and we'll fix it.
I'll get one more. Let's say you're signing.
Oh, thanks. Good morning. Good morning, Toto.
I saw the 90.
Can you guys over in 202 hear me?
Yes.
Awesome. All right, so let's start, jump right into cognition. What kind of things do you think are involved with cognition? Do what? There's a lot of things involved in cognition. What kind of things do you need to be concerned about when you are assessing? How are you going to assess someone for appropriate cognition? Alert, to see if they're alert and oriented. What else? Okay, yeah, you have to know that you're getting the right information. Because they're sneaky. You have to be careful. If you ask a yes or no question, and they'll just answer whatever they think that you want them to answer. So we're going to jump into cognition. Here are your learning outcomes that are on your unit outline. So we're going to look at the definition. We're going to talk about a couple of different illnesses and issues with memories and an executive function of the patient with an impaired cognition. We're going to talk about assessment of cognition. We're going to look at who's at risk across the lifespan, because it does affect people across the lifespan. All ages, all stages. We're going to look and see how acute and chronic illnesses affect cognition. We're going to look at evidence-based therapeutic interventions that we use as nurses to help provide safe, quality care. We're going to evaluate methods of therapeutic communication for our patients with impaired cognition. That can be rather difficult sometimes. And we're going to talk about community resources for patients and their family. It's not on there, but it's also family resources. So this is the definition that we decided on as Mary Grimes School of Nursing. And it talks about that it's a mental action or a process that we acquire knowledge and that we gain understanding through thought and experience in the senses. So our cognition grows through our life, and then it starts declining as we get older sometimes. The scope of cognition, what we have, so for cognition, we have normal or we have impaired. So we have to determine where our patient is on that scope. Like I said, it can change over time. There are things that are going to change it. What might be something that happens that would cause a change in a person's cognition? A stroke.
Overdose.
An overdose. Thank you. I'm sorry, what? A traumatic brain injury. Yeah, any Alzheimer's, dementia.
Shock.
Do what?
Shock, like during a trauma, like Natalie said.
Okay. And then sometimes autism will not show up. They'll be fine as infants, and it might show up when they're 2 or 3 years old. So those are some things that might cause a change over time. Oh, went too fast. So cognitive development occurs predominantly from infancy through adolescence. It might be a less dramatic development, and maintenance of cognition occurs during adulthood. So that means we have to keep using our mind to keep our brain processes good. One of the things that they have started with as people grow older is to have them play mind games or do crossword puzzles, something to keep them thinking, especially those people who are maybe are disabled or retired. If they just sit there and watch mindless TV all day, or I know I'm probably going to offend somebody, but play video games all day, that may not keep them stimulated enough to keep their cognitive process growing. So to help with memory function, they really encourage that, that people play, use mind games or crossword puzzles or something to keep them intellectually growing. Cognitive impairment or intellectual loss is usually may not be a part of normal aging, but it's usually indicative of some kind of disease process. Consequences of cognitive, because not everybody gets dementia. You have 90-year-old people running around that are very alert and oriented and don't have dementia. And then you have the early 70s that have dementia. The consequences of cognitive impairment can be devastating, and it's going to affect not just the person, but their whole family and their friends. It might bring on a role reversal in the family. I know watching my mom and dad, my dad started getting dementia and he just kept going downhill. My dad, when I was growing up, he was a smart man and he was very good mathematically and he paid all the bills. And I didn't know this until I was an older adult, but he paid all the bills and he invested wisely and he was really good that way. And so he started having memory issues and my mom had to start taking over that role that she'd never done. And so there's that role reversal. And there's also emotional changes, not necessarily with the person that's affected with the cognitive impairment, but also with the family member. Because someone with dementia and Alzheimer's, it can be really hard to take care of them. And I saw that in my parents. My dad was not quite as strict and rigid as he used to be, but my mom was a lot grumpier and sometimes she was mean to him because it was a burden on her. So we have to think about how the cognitive impairment is not only affecting the patient, but how it's affecting their family members too. So some key components that we think about with cognitive impairment is we want to look at their perceptual motor function, their sensory perception. How do they interpret the environment around them? They might have some language issues. And sometimes it's not that they can't speak, it's that they can't figure out, their brain and their mouth can't figure out, they can't figure out the words they want to say. Cognitive impairment will affect learning and memory. And remember, memory is the recall and retention of past events. Sometimes our patients we see with dementia and Alzheimer's can remember things from a long time ago, but they can't remember what they had for breakfast 2 hours ago. It's gonna, a cognitive impairment is gonna affect their social cognition. My dad was always a very friendly, outgoing person, and the further he got into dementia, the further he retreated into himself. He'd talk to anybody, but the further his dementia progressed, the less he became. He wouldn't talk to hardly anybody. Cognitive impairment may bring on complex attention. They have that short attention span. They get like the 2- and 3-year-olds that have a short attention span. And it's going to affect their executive function. And this refers to higher levels of thinking and their flexibility. Sometimes people with cognitive impairments are very rigid and want to be very structured in their schedules. And that's really important for them to help them day to day to have that rigid structured schedule. My sister-in-law has Alzheimer's And if she gets out of her environment, out of her little world, she has a panic attack because she doesn't know how to be flexible. She can't deal with that. They're not good at adapting to new places or new schedules. And they have to have goal-oriented directions.
Hey, Christy.
Yeah.
So when you were talking about the social cognition where they retreat into themselves, is part of that just because if they have trouble remembering or their personality changes, that's like they do that just not to interact with people, or is that an effect of the actual like dementia or Alzheimer's? Does that make sense?
I think that it might be both. Some of it might be that they're embarrassed because they can't remember things and so they don't want to talk to others. I think some of it is just a part of the disease process where they just become, they want to isolate. And of course, my dad's could have been because he was getting towards end of life. And
Right.
So that may be, but sometimes you do see them isolating because it may be because they're embarrassed that they can't remember things, or it could just be a part of the disease process.
Okay, thank you.
Uh-huh.
Christy, what was the last thing you said? I think like after not adapting to new things.
The executive function. Is that what you need?
There's something else, I think.
Not good at adapting, they need goal-oriented.
Yeah, there you go.
Oh, yeah. The adaptability, and they need goal-oriented directions. We need to help them set goals to achieve. And they need to be very simple for our patients. And this could be our patients with autism. It could be our patients with some kind of a learning disability, or it could be our dementia and Alzheimer's patients. Good questions. Anybody else? So our two exemplars for cognition, one is Alzheimer's, and here's what I'm going to say. Alzheimer's and dementia, although they're slightly different disease processes, they kind of go along the same trajectory. So they're very similar, and we do the very similar things for them. So with Alzheimer's, what they see on a CAT scan is extracellular amyloid tissue and beta plaques in the brain. They also see neuronal death, and there's loss of synapses that contribute to progressive cognitive decline. The thing with dementia and Alzheimer's is it's slow and progressive. Alzheimer's can show up in people as young as 50 years old. I know my sister-in-law was probably in her mid-50s when we started seeing signs of memory issues. Dementia usually occurs with our patients that are maybe in their 70s or 80s, but it can occur earlier too. I think with dementia, they don't necessarily see the same breakdown in the brain tissue as they do with Alzheimer's. And Alzheimer's is a form of dementia. Remember, when you're educating your patient and your family, Alzheimer's and dementia are irreversible. There's nothing we can do to turn it around. There are medications to help slow the progression, but there's nothing to fix it. And there's no prevention or cure. So that's something that we really need to talk to our patients and our families about. If they ask, we need to be truthful and honest. I remember my dad, he had an older sister that had died from Alzheimer's, and he had a really stressful year with farming, and he was having some little memory issues, but I didn't think it was bad, but my mom thought it was bad. And she wanted him to take, because there is a blood test, I guess, to tell you if you are, if you can get Alzheimer's, and he didn't want to do it. And she was mad at him for not doing that. And she was mad at me for saying, well,
would you want to know? Because she has Alzheimer's in her family. Anyway, it was a whole big thing. So anyway, so there are tests that, and it's going to have to be up to the family members to decide whether they want to see if they're possibly going to come down with Alzheimer's. And we're going to talk a little more about Alzheimer's and dementia. Down syndrome, this is caused by, this is a birth defect, and it's caused by abnormal cell division of the chromosome 21. It causes genetic variations, and it's similar to trisomy 21. It causes intellectual and cognitive disabilities, and there are characteristic facial features. When these kiddos are born and we're doing our assessment, their ears are low set. The top of their ears are going to be level with their canthus, eye canthus. And they're just funny looking kiddos. We used to call them FLKs, funny looking kids. But, and as far as intellectual disability, they can be at a very high level of learning disability, or they can be at a very low level. So they're at different stages. One of the things that's great about the Down syndrome people is that they used to think that they couldn't do anything, and they institutionalized them. And now they're finding that they can, with a para, they can actually mainstream them into the classroom, and these kiddos can learn. And there are some that have graduated from college. There are some that have their own businesses. I don't remember what her name is, but she started like a bakery, and she has other people with Down syndrome that work in her bakery. And I think her parents help her, but this was something that she started on her own. This was something that she planned and wanted to do. So no longer should they be considered uneducatable, because they can be educated. They want the same thing as children and adolescents and adults as people without cognitive disabilities. Down syndrome people are at additional health risk as they age. They can develop dementia or Alzheimer's. My husband had a cousin with Down syndrome, and he got dementia in his 50s. By age 40, almost all brains of someone with Down syndrome have some type of protein deposits that are hallmarks of Alzheimer's, but not all of them develop dementia. It's just like in the rest of the population.
What does Down syndrome do? Like, how does it affect their daily life?
It depends on what cognitive level they're at. Their daily, it just depends. Are they high functioning or are they lower functioning? So it would be like any other child with a learning disability. It would be like any other, a child with autism. Some of them do not learn very well, and they stay childlike all their life. And some of them will grow into adulthood, but they won't be able to learn as easily and readily as other people. It's a learning disability. So Down syndrome, it just depends on where they are at on that cognitive level. They're all going to be different. Some of them learn to, like other children, to get up and dress themselves and brush their teeth and get ready to go to school. They can study and things like that, feed themselves. So it just depends on where they are on that spectrum of cognitive impairment.
Christy?
Yes.
Can you repeat what you said about protein? And then also just, you don't have to like completely slow down, but will you just a tiny little bit so we can write down?
Yes. So they think that they've observed with CAT scans by age 40 that almost all of the brains of the people with Down syndrome have protein deposits. And these are considered to be hallmarks of Alzheimer's disease. But not all of them develop dementia or Alzheimer's.
Thank you.
And then they say at age 65, more than 75% of Down syndrome individuals have Alzheimer's disease. Huh? 65. 75%. And you won't need to know this. It's not going to be on the test. And this is nearly 6 times higher than any other age group. So they are at risk because they're missing that chromosome 21. The other thing about patients with Down syndrome is they also have a propensity to have some kind of cardiac disease. They might be valve prolapses, or it can be some kind of heart condition. And it used to be, before we had all the cardiac medicines and they could have surgery, that these people didn't live past their late teens, early 20s because of the heart disease issue. So people with Down syndrome, they'll develop changes in their overall function. Here's the thing about Down syndrome people. They're very caring, they're very kind, they're very loving, they're very generous, but they can be very stubborn when it is something that they want. So just think about that when you're working with a patient with Down syndrome. This also can be your autistic patient, as well as maybe people with other people with learning disabilities. So we have to think about what's the best way. We have to look at their functional ability. And most of them move very well. They like to participate in Special Olympics or in those kind of things. They like to have fun. So most adults with Down syndrome don't self-report concerns about memory loss. But as they get older, we need to start looking at it. And that's where we need family or people that know them to tell us, okay, is this normal or is this something new? Sometimes it might be difficult to diagnose dementia or Alzheimer's in these patients. So hopefully there's been documented baseline adult behavior by age 35. We'll need to encourage the family members to watch for changes in their day-to-day functions and their ability to perform ADLs. We might need to consider a professional assessment by someone that's a dementia expert. And then again, like for dementia, early dementia, we need to rule out other causes that might be causing their decline in their memory and their cognitive impairment. Okay, so what I want you to do, there is a difference between dementia and delirium. And sometimes delirium gets mistakenly diagnosed as dementia. So I want you to get in groups. There's a slide in your handouts. There's also, oh goodness, I meant to write it down. In your Med Surg book in Lippincott, it's in chapter 11. There's also a chart that talks about Alzheimer's, dementia, and delirium. So get in your groups and talk about the differences between dementia and delirium. And then we'll talk about it later on. So go ahead and do that. And I will look up that page really quickly.
Unit 2.
Here it is. Yeah, 210 is
I didn't realize that all sections.
I mean, I don't know why.
Like dementia, a little bit later. Also, very staff. Well, especially if you
Yeah. All right. The chart is on page 210 in the Med Surg nursing book in your Lippincott, and it talks about Alzheimer's, dementia, and delirium. I'll give you about 5 more minutes and then we'll move on.
Oh, yes.
Okay, we'll talk about the difference between dementia and delirium here in a bit. So this is your patient. This is a dementia case study you have in resources. This patient is Butch, William Welka. He's 72. He has a history of heart failure, COPD, hypertension, diabetes type 2, and dementia. And he's been hospitalized several times recently for exacerbation of his heart failure. 3 times in 6 months. That's pretty frequent. So his family, his wife, felt like she couldn't take care of him anymore. So she and the family decided he needed to go somewhere where there would be other people to help him because his dementia is progressing and she's just at her wit's end. So he's at Pineville Estates. So we'll be working with Butch. So you might want to have that case study handy. Yeah, the dementia case study. It'll have his picture on it. Yeah, it's a dementia case study. There's an Alzheimer's case study, but it's a little different. And here's what I want to tell you. The test is mostly comprised of questions about how to care for dementia and Alzheimer's patients. So when you're studying, that's what you want to be studying. You need to know how to take care of anybody with an impaired cognition. But your test questions are going to be, there might be a couple about learning disability patients and how to care for them, but there's not going to be specific Down syndrome questions. The majority of them are either dementia or Alzheimer's. So when you're studying for the test, that's how you need to study. That's where we're going to spend most of our time. So when we're talking about lab tests or diagnostics, there's really no definitive lab test, blood test to diagnose Alzheimer's. We can do lab work to rule out other causes of dementia or delirium. So this is where we're going to talk. What might be some causes? Let's do this way. What is the difference between acute onset confusion and progressive? Yeah, acute is suddenly. You have your patient who is normally alert and oriented, and 2 hours later, they don't know where they are. They think that you're in their house. They're all confused. That's acute. Remember, dementia and Alzheimer's, that confusion comes on slowly. It's progressive. It doesn't happen right away. They don't wake up one morning and they're in bad dementia. Delirium, they can go to bed one night, wake up totally confused. What might be some conditions that might cause that acute confusion? A UTI. In elderly, a UTI will cause that acute confusion. That is probably the #1 cause of delirium in your elderly patients. What are some other things that might mimic dementia or what? Yeah, any type of infection, sepsis, good. What else? Do what? Yeah, a drug reaction or a drug interaction. That we see that with our elderly. We have to be really careful with our older patients and the medicines that they receive, because sometimes that medicines can make them confused. Good. So we're going to talk about some more of these, but just think about the difference between the acute confusion and progressive. If it's an acute confusion, is that going to be reversible? Yes, as long as we find out what's causing it and correct that problem. So back to the lab test. There are, like I said, there are genetic testing for the presence of the protein that can determine if the patient might be at risk for getting Alzheimer's disease, but it's not specifically a diagnosis. People who take the genetic testing, if they have the protein, it increases their likelihood of dementia due to Alzheimer's, but it's not a definitive diagnosis. The only way that they can definitively diagnose a person having Alzheimer's is post-mortem examining the brain after death. They can, on CT scans, see the amyloid tissues that are degenerating, that they can say, well, this is probably is causing their memory loss and dementia. One of the diagnostic tests that we do, and every facility is going to have a different type of test for their mental status, but in your handouts, there's a mini mental status exam, and I'm going to share that. Oh, I think I have it. So this is one, and it talks. It's going to ask them to do different words. So there's like the 3-word registration. So you give them 3 words at the beginning, and then later on in your interview process, you ask them what those 3 words were. Now, I'm not sure I could do this. But anyway, So you might have them do a clock drawing. You might have them do a 3-word recall. And then you score them. So here's the clock. There's a myriad of different ways to check your mental status. What are some ways that you can do without having a specific mental status? What ways are we going to use to assess our patient's cognition? We kind of talked about it earlier. Well, we're going to ask them their name and date of birth, right? And if they give us a correct name and date of birth, then we need to, and we think that they're impaired, we need to go a little further. What's something else that you can ask? Okay, what's today's date? Now, here's what I'm going to tell you about your patients that are ill and in the hospital. If they've been ill for a while, they may not know what day of the week it is. But the year works really well because that's consistent for 12 months. What else can we ask? Yeah, who the president is. Where we all want to know, do you know where you're at? I had one little elderly lady, and hers was more delirium because during the day she was alert and oriented, but at nighttime she got as confused as all get out. And she swore up and down we were in her house. And she got really angry. She had a roommate. We were afraid she was going to hurt her roommate, so we had to move her roommate. And then she followed us moving her roommate down the hall. And then she socked me in the nose. So anyway, so she had that sundowning syndrome or whatever, because during the day she was fine, but at nighttime she got really confused. So we have to think about that. And try to figure out. I think we decided hers was some medication she was on. So you want to keep asking them questions to elicit, to see, okay, how well are they functioning? And then you might go, if you're in after breakfast, you might ask them, what did you have for breakfast? My father-in-law had dementia, and he would tell us towards the end of his lifespan, he would tell us every morning that he had biscuits and gravy. And we knew that wasn't true because they didn't make biscuits and gravy every day. So, but he could talk about his time in World War II, and he could talk about growing up, and he remembered all that, but he couldn't remember what he had for breakfast. So you have to think about how to do that. There is a confusion assessment method, a CAM method. It's in your resources. They can do an MRI and PET scan for brain image. And usually they might refer them to a neurophysiologist, neuropsychologist. All right, so before we get into the delirium, let's go ahead and take a break, come back at 10 o'clock, and we'll finish up. We'll get into the case study.
Our midterm review, we're supposed to do it together, the midterm review.
Monday afternoon is the remediation,
Okay.
and you're going to get your test back, and you're going to do the problems that you
No,
missed.
for they call it the midterm check.
Oh, the midterm
to do
for
that.
practicum?
In the,
I know I had it in PNC, but that's over.
oh, okay.
But there's one in practicum that your clinical instructor does.
Okay.
I'll talk about it, and I'll come back. There's two of them.
Okay, I handed out a new student testing policy because we did revise the review of the examination. That's what was changed. What I need to do is you need to sign the sheet and turn it in to me. It doesn't say that you're agreeing to it. It just says that you've been given the new test policy. You know there's a new testing policy and you're just acknowledging it. So if you would please sign those sheets.
What is it? Yeah, could you just explain it to us?
It is under the heading student test review. And there's probably not a lot of changes, but one of the things that we did put in here, because it wasn't in the other one, is that you couldn't take notes, and that that final examination, we won't do a review after your final exam. Because everybody has to be there if we have a test open to conserve the integrity of the test. So most people, once they're done with the final, they leave. So we just have never done it, but it's not been in the policy. So faculty, that was faculty decision. Yes?
Yeah, so I'm just reading here, it says the review is to be understated in the state so they will not be repeated and not to argue and negotiate the answers. So are we still able to email?
Yeah, you can still send in questions that you have concerns about. We'll let you do that, yeah. That doesn't eliminate that. So just, this sheet, it's not that you agree with it, the signature sheet, it just says that you have been given the updated policy. And just make sure that they all get turned in before you leave today. All right. All right, so this is the slide about dementia versus delirium. And there is that nice one in the textbook that also has Alzheimer's disease in it. Remember that delirium is an acute condition brought on by an illness or toxins or medications. UTI is the most common in the elderly, and delirium is reversible, whereas dementia and Alzheimer's is not.
So where is like acute confusion? Is that like more delirium or?
Yeah, acute, yeah. Here, I keep walking away from my microphone. Acute, oh, stop it. Acute confusion is like delirium and acute confusion. There's something that has made them confused all of a sudden, and if we figure it out, we can reverse it. Whereas dementia and Alzheimer's are progressive. It's a slow progression of memory loss. We start to see little things like they can't remember where to put their keys, or they can't remember how to drive to the store that they've been driving to for umpteen years. That's the thing with the difference between delirium and dementia or Alzheimer's. This video is really good. I'm going to let you play it at home and listen to it. It's about 3 minutes, but it talks about the difference between Alzheimer's and dementia. So a mnemonic for conditions that mimic Alzheimer's disease or dementia, this is really good because it gives you a list of what could be causing that acute confusion. And we talked about some of those. Tumors are a big one. If all of a sudden someone's confused or having trouble with their memory or having trouble learning new things, then that might be a tumor. It needs to be investigated. So this is a great mnemonic for dementia, for things that can cause acute confusion, and we might think that it's dementia or Alzheimer's disease. So early stages of Alzheimer's disease, we see forgetfulness. It might be very subtle. Sometimes people can hide that very well, especially if they know it's happening, but they don't want to know it. They don't want anybody else to know it's happening. They might experience small difficulties if they're still working or if they're doing social activities. They still may be able to conceal that they're having those cognitive changes, and they're still independent. The middle stages, people can see that there's a problem, other people. The forgetfulness is seen in daily activities, and patients might lose their ability to recognize familiar faces, going to familiar places or objects, and they might become lost in a familiar environment. My mom and dad went to Walmart, and he was in the little motorized cart, and she was up at the front waiting for him, and somehow he got past all the employees and went out the back door of Alzheimer's. Of Walmart, they had a horrible time finding him. So, and he rode around Walmart a lot. They have a tendency to repeat stories or questions. And sometimes they're very stubborn. Trying to reason with someone with dementia and Alzheimer's and using reality orientation only increases their anxiety, but it doesn't help their function. So we have to kind of determine if we're going to do reality orientation or not. They can get very agitated. They sometimes have trouble with conversation because they struggle with finding the appropriate words while they're talking. We talked about that. And they lose their ability to organize concepts and think abstractly. And they might have difficulty recognizing consequences for their actions. I know I'm talking about my dad a lot, but this was, watching him progress was very eye-opening at times. And I don't know why. My mom decided that they needed a Yorkie puppy. So they got a Yorkie puppy. Well, my folks, we grew up on a farm, and our dogs were always outside and they ran free. The people next door to my folks they were in a small little town, thank goodness. But the people next door to them had a little Yorkie that ran all over town. But my dad couldn't understand that if the puppy ran away, if he let the puppy out and she ran away, she might not ever come back. And there were big battles over that. So he couldn't understand the consequences of his actions. They might have very impulsive behaviors. And they might start having trouble managing money or operating simple appliances. My mom had to take his credit card away because he'd see something advertised that was going to help his pain, and he'd order it, and then when it came, he didn't know where it came from. So there might be personality changes. They might become depressed. They might be suspicious that people in the household are trying to get rid of them. They might become paranoid. They might become hostile or even combative.
This is still in the middle stage.
Middle stage. And then in the later stages, we see those symptoms intensify. Their speaking skills deteriorate, and they may speak nonsense or garbled words. They're easily agitated, and they may start to wander. My dad was a fall risk. He was in the long-term care unit, and I was in Wichita, and I had a short time that morning to see him, and I went to see him, and nobody knew where he was because he was in his wheelchair, thankfully, but he wandered off and nobody knew where he was, which really made me kind of frustrated. And we found him in another patient's room looking out a window. Now he had a window in his room that looked out over a really pretty lawn and trees and the street, but he thought there was a better view from that room. So they do wander if you don't watch them. They may become aphasic, where they don't speak. They're going to have a decrease in orientation. Their forgetfulness and repetitive speech is going to intensify. These people might have a delay in their thought processes. So if you ask them a question, you might have to wait just a little bit to let them answer it because they have to, their thought process is slower. And they may come up with the correct answer, but they just need time to think about it. You might start to see attention deficit in the late stages. And their ADLs are going to become more difficult for them to perform as the disease progresses. They could have behavioral changes. They could become agitated or more aggressive. They might have mood swings. You might see their sleep cycles interrupted, and they might become insomnic. This is where it's very difficult for those caregivers at home. If they get up at night and wander, because they could wander out of the house and walk away and get totally lost. These are the people that, especially in the winter, they find them frozen, which is really sad. My great aunt, my Uncle Joe, he had Alzheimer's, and she put a bell around his ankle so that she knew when he was getting up at night. They're gonna have dysphagia, trouble swallowing, so their nutrition is gonna suffer. They may decide to quit eating. That's what my dad did. They're gonna have trouble expressing feelings. And at late stages, you might find them, at the very late stages, they're gonna they're gonna become bedridden and they're gonna curl up in a fetal position. So what are some things, if this patient becomes bedridden in a fetal position, what are some things that you can do, that you need to do for these patients? Hygiene. Yeah, make sure you're turning them at least every 2 hours. Maybe passive range of motion to keep their muscles in their legs from getting stiff and so contracted that we can't get them out of that. Our Down syndrome patient, we talked about, they may have vision or hearing deficits. They may have thyroid dysfunction. They may have sleep apnea. They have short necks. They have sleep apnea. We may see them having some celiac disease, GI disturbances like GERD, anemia. They might have a propensity towards constipation. They can become anxious and depressed. And then those cognitive and intellectual delays and developmental delays. They, like I said, they might have behavior and mood changes. They may be more prone to seizures and epilepsy, and they may not know how to express their feelings. And then with the Down syndrome patient, as they progress in age, we need to watch for signs of dementia or Alzheimer's. So who's at risk for a cognitive impairment? Everybody, because it can start with a genetic problem like Down syndrome. You have your autistic kids that usually shows up sometime between the age of 2 to 4. You may not know about learning disabilities until they're school age. And then as we advance in age, we might have chemical imbalances that and things start happening in our brain, deterioration, to cause Alzheimer's and or dementia. A family history for Down syndrome or any type of genetic predisposition probably should be explored. We also need to think about environmental agents like metal, lead, toxic waste, the herpes virus, if the mom has the herpes virus while she's pregnant. Head injuries, previous head injuries. Females, it says, has more tendency to have problems with Alzheimer's or dementia. And then some ethnicities have problems with developing Alzheimer's disease. But it's across all ages. Cognitive impairment is across all population groups, and it's all ethnicities. Does it? Predominantly male. We see a lot of that, but for Alzheimer's disease, yes? Oh, okay. So let's talk about medications that you need to be aware of.
Well, so which one should we go off for the test? Female?
It won't be on the test. Oh, go with what's in your book. Male. So medications, these are medications that are used for to hopefully slow or the progression of dementia or Alzheimer's. Namenda, it binds NMDA receptor sites, and that prevents binding of glutamate. It just helps slow the progression of the disease. It involves learning and memory. So some nursing implications for this, side effects are headache, constipation, acute confusion, dizziness. Teaching, treatment of dementia might be, it's used in moderate to severe patients and or Alzheimer's disease. It doesn't alter the underlying disease process, and we have to use it in caution with patients that have liver, bladder, or renal disease. And the good thing about Namenda, they come in a capsule. You can open these and sprinkle them on applesauce if patients have difficulty swallowing. Aricept is another medication. It helps inhibit acetylcholinesterase, and that improves cholinergic function, making more acetylcholine available to the brain. Side effects that we need to watch for are nausea, vomiting, and diarrhea. Those are pretty common with almost every medication. Headache, dizziness, fatigue, twitching. It can cause cardiac dysrhythmias, insomnia. So if you have a patient that's already insomniac, we wouldn't want to put them on this.
Do we need to know the medication for the test?
I don't remember. I don't think so.
Okay, when you're going through the meds, can you talk a little slower?
You know what? I'll just type this up and send it to you.
Okay.
I'll put it in resources.
Thank you.
So, and you might want to look them up. Most of these are going to cause headaches, but and other things you need to know. Make sure that your patient's not having any type of liver failure or kidney failure where the medication's processed through. I'll get this, I'll put this in resources.
Thank you.
So what are some non-pharmacological therapy? I know we talked about sometimes reality, orientation to reality might cause them to be more agitated, but if you were going to do that, what kind of things would you do?
Just put up signs,
What kind of signs?
day of the week or month it is, maybe?
Yeah, put up the day of the week. So today's Thursday and it's April 1st. That's good. What else? A clock is always good. How else can we orient them to reality? If they can still read, give them a newspaper of the day, because that will have the date on it, and it will be current. So what does anybody know what validation therapy is? Yeah, we're looking to see searching for the emotion or meaning in their verbal expressions. So we're looking for those, what they're saying, and trying to help them come up with ways to help them understand what they're feeling. What about reminiscence therapy?
Is that like thinking about the good old days, like talking about their memories or past events?
Yes, that's exactly right. It's talking about having them talk about their things in their past life, things that they might be proud of, like their grandchildren or their children, or their job, or what they did when they were young. And this is where, hopefully, if they're in a skilled facility, they'll have pictures on their walls of past events. Maybe even if it was 50 or 60 years ago, they still have a wedding picture up, because that might be a happy memory for them. And then some types of complementary health approaches. They might use art therapy or music therapy, healing touch. Do y'all know what healing touch is? That's actually becoming pretty popular. It's a little different than massage. It's very purposeful. It's to help get rid of the bad energy. And so you have to be specially trained in it. Not everybody can do it. Yeah, something like that. But there are nurses that go to courses to become, that they can use healing touch. Yeah.
Chris, can you tell me an example of validation therapy again?
Validation therapy, that's how we're going to help them look at their emotions and the meaning in what they're talking about in their verbal expressions. Because sometimes things come out and they're like, I don't know why I said that. And so then you can ask, use that therapeutic communication and ask them questions and figure out and maybe help them understand, okay, I'm sad because I'm not the same as I was before. That's kind of validation therapy. Does that make sense?
Thank you.
So our priority focused assessment, we need to observe the patient, and while we're doing the patient interview, remember to ask them, use therapeutic communication. Try not to use yes or no questions because they may tell you the truth or they may not, because they may not know that they're not telling you the truth. You want to do some kind of a cognitive mental status exam, and your facilities will have the one that they use. We need to do a head-to-toe assessment on these patients because they usually have other illnesses, chronic illnesses, besides the dementia. We need to see how their behavior is. And then we need to check on the caregiver if they're living at home. What are some things that we can do to help caregiver fatigue?
Respite care.
Yeah, maybe encourage respite care. What'd you say, Crystal? Oh, you said the same thing. So yeah, we need to encourage the caregiver because they're caring for these people 24 hours a day, 7 days a week. So we need to encourage them to take some time for themselves. If it's the wife, I like to encourage them to go get their nails done, go have a nice manicure and pedicure. But also you need to encourage them to have there are some long-term care facilities that have short stays where they can put their family member in that short stay so that they might be able to go take a week's vacation because they need that downtime. They need that relief. They need that good night's sleep without worrying about whether their loved one is wandering outside. So it's really important to take care of our caregivers as well as the patient. So when we're thinking of management of care for this patient, what is our first priority for someone with Alzheimer's dementia? Safety. So that has to be our number one concern. We have to know if they're a fall risk. We have to know if they're a wanderer. Most of our long-term care facilities now have alarms on their doors. So they can put like special bracelets on their arm that if they get too close to the door, it goes off. But sometimes they're sneaky and they can sneak out. We want to promote a healthy lifestyle. And for our patients, our families that are looking to get pregnant, we need to ask them about if they have any genetic predisposition in their family for Down syndrome, Huntington's disease. In our patients that the physician is diagnosing with dementia, Alzheimer's, we want to know about family history of that too. We can suggest genetic counseling. And for screening, we might do labs to rule out other causes of Alzheimer's and dementia, as well as other comorbidities. That's primary prevention. So our secondary prevention, that's where we're going to do some kind of a mental exam, a cognition exam. We're going to do collaborative care with home health if they're at home, physical therapy, respite care, support groups for the family. And then helping them talk about bringing in social workers to talk about placement in a long-term care facility. We need to have a proactive plan of care. And then we need to, if we're working in a long-term care facility with the Alzheimer's dementia patient, we need to be really proactive in looking at medications and therapies and making sure they're doing what they're supposed to be doing. We talked about family and caregiver support, nutritional support. They're getting to the point where whatever, even if they are diabetic or are supposed to not have salt, whatever they'll eat, give it to them because they may not be eating very well. Doing activities. My dad loved music, so every time they had music activities, we made sure he was there. In the early stages, you might help the patient and with coping skills, but you're probably going to help the family too, especially that primary caregiver. And then you're going to have to talk to them about end of life decisions. What do you want for end of life? We brought in hospice because we wanted my dad to be comfortable at his end stages of life. So we have to help the patient and the family set appropriate goals. For the caregiver, you know, we talked about having a backup, an alternate caregiver, so that they can, if the main caregiver gets ill, or because we're talking about, you know, if this Alzheimer's or dementia, these patients are in their 70s or 80s and their spouse may be the same age. So they may or may not be able to care for them. If they're in their 80s, they may have children that are in their 60s. And if they're not in very good health condition, we need to figure out a way to keep both of them safe. The one thing that I do want to talk about is our dementia patients, our Alzheimer's patients at home, they're at high risk for elder abuse. So we really have to think about that. We need to make sure that their environment is safe, so they're probably going to need home studies. We need to talk to the family about who's going to make decisions, getting that power of attorney, and advance directives to tell us what kind of treatment they want at end of life. With each other, we need to talk about stigma or stereotyping. And we also need to talk to the family members about their role reversal. Remember that sometimes these patients and even the family will deny that there's anything wrong. And so we have to educate them on why it's necessary to diagnose this early. We might think about spiritual care, cultural care, and then we need to figure out how to support and help this family and caregivers. And we might need to help teach the caregiver therapeutic communication. My mom would get mad at my dad and she'd yell at him and he'd laugh and that would make her madder. So we need to think about therapeutic communication. We need to discuss coping mechanisms if it's early stages with our patient. Talk about coping mechanisms and skills to help promote quality of life. We also need to talk to the caregiver. And then again, it's so important to bring in that interdisciplinary team to help coordinate and manage care, to keep the patient safe and the caregiver safe. So again, these are things that we need to educate the patient and the family members about. And we need to tell them that it's okay if they're experiencing that wide range of emotion. If one day they're happy and the next day all they can do is cry, that's normal and that's okay. But they need to find somebody to talk to. And tell the caregiver that as the disease progresses, they're going to have to find really good ways of coping and have a good, strong support system to help them get through that. We're going to have to educate them on how to have good health promotion. And we need to remember, we're not just treating the cognitive disease impairment, but we're also treating their other chronic conditions. And we need to tell the patient and the family, it's okay to grieve this loss of their cognitive ability. It's like losing a limb. So this young man's Darren. He's 16 years old. He has Down syndrome. He's really active and he likes sports. He is in the Special Olympics. He does have some mild learning disabilities, but he's been able to mainstream in the classroom, and he has a paraprofessional that works with him. His parents have started noticing that he's having some behavioral issues at home, being aggressive and not being compliant and doing what he's supposed to do, and they're getting frustrated. Darren has a mitral valve prolapse that he's coming in to have surgery for. So, and that's the only health condition, his mitral valve prolapse. So he's coming in for preoperative admission, and you are the nurse that's taking care of him. So what kind of things are you going to do to help make this a productive session? Because you need to get an assessment, do vital signs, and he's kind of belligerent and doesn't want to do anything. So how can you help Darren be compliant? Okay, help him to have control. What kind of ways can you, what kind of things can you do to give him a little bit of control? Okay, ask him about how to do certain activities. So you could give him a choice. Which arm do you want the blood pressure cuff on? Do you want to put the blood pressure cuff on yourself? If you're using a pulse oximeter, put this on one of your fingers. Give them some choices. What else? Because you're going to have to do surgery education. So what kind of things are you education? What level might you use to help educate Darren? Yeah, so we have to figure out where is he at? What grade level is his understanding? We might have to show pictures when we talk about that. And we need to help him practice. We need to get him a pillow that he's going to have over his chest, incision, to take deep breaths and cough, and help him practice it. Would making a game out of that be good, maybe, for Darren?
Since he likes sports.
Yeah, since he likes sports and games. So if you make a game out of, there are some things you don't want to make games out of, but using that pillow, so it's like, okay, show me how many times you can put that pillow on your chest and how many deep breaths you can take.
Hey, Christy.
Yeah.
So on the test we just took, one of the possible answers was talking about for an adolescent making a game out of using, what was it? Like a meter, and the explanation was like very clear that that was not a good idea because it was not a game, it was a serious health issue. So yeah, but that's what I said. I clarified that. You don't want to make a game out of everything, but if you're teaching him how to use the pillow to take deep breaths, that might be a good way, or use a sports analogy or something that he can relate to. okay.
The inhaler, you don't want to make a game out of it. No, because that's medication. And I'm not saying for his medication, we're not going to make a game out of it. But we want him to take lots of deep breaths. So we need to get something that he can relate to that he would do because he enjoys it. Does that make sense? What else can we do to educate Darren to get ready for surgery?
Make sure you're not taking forever because they have short attention spans.
Making sure you're not taking forever to do what?
Just making sure that your education is like accurate, but you're not taking forever because people
Yeah.
usually have short attention.
Yeah, it has to be very concise and direct, and the attention span. That's a very good point. I thought of something. You might, if it's possible, you might take him into the surgery suite so that he can see the room he's going to be in and all the equipment, so that when he goes in, he's not scared. Because going into surgery even for adults and seeing all the equipment and all the people, it can be kind of scary. So you might think about things like that. So just think about ways to help Darren. And then what might be some things that you can talk to the parents about, maybe to help with his behavioral issues at home? Yes.
Going back to the control, like if you give him choices, like if he has to participate in daily chores, like you can choose either do the dishes or set the table. So
Okay. Good. So yeah, you might encourage the parents, make sure you're giving him choices. So you give him the choice. You either set the table or you do the dishes afterwards. And so he can do that. Or you sweep the floor or take the trash out, whatever the chores are. That's kind of where I was thinking too. What other things might help with behavioral issues? Rewards, if he does something that he's supposed to. And then if there are negative consequences to his actions, they need to be sure and carry those out, right? Okay, so that's Darren. All right, so pull up the case study about Butch, the dementia case study. Nope, that's not it. Maybe.
Chrissy,
Yeah.
in this class, we learned a lot about like causes, signs, symptoms, but our exam's going to be over how to take care of these patients during these times. So that being said, where do you feel like we need to be looking at our books to be able to figure out how to take care of these patients?
Look for the nursing care. Look for the interventions. Think about what we do with these patients. Safety first, or reality orientation, things like treating, what their comorbidities are and how that's going to affect them, things like that. And we're going to kind of talk about that in this case study. Assessment, you need to know assessment, what assessment you need to do and what might be expected assessment findings and unexpected findings. And nursing interventions. I'm trying to, oh, I just closed my book. I have some questions we're going to do here in a bit. Hopefully they'll help us. Think about ways to help the caregiver. Oh, I'm going to pull this up. All right. So let's go to the questions and then we'll look at the case, some parts of the case study. So this is your first question. The nurse is developing a nursing diagnosis or patient problem area of self-care deficit for older client with dementia. Which of the following is an appropriate goal for this client? So I have somebody said number 3. Anybody have anything else different?
Number 1.
Number 1. Anybody else have anything different? Okay, So the correct answer is number 1. We want to maintain our patients' highest level of independence, highest level of functioning, to maintain their independence as long as possible. I gotta go back. Number 4, they don't all need to go into long-term care at the beginning. And not all of our patients with dementia or Alzheimer's go to long-term care. Sometimes families keep them at home. Or that's number 3. And so they can't necessarily complete all activities of daily living because they have some cognitive issues, so they might need help with that. But we want them to maintain that high level of functioning. So this question, the home care nurse is performing an environmental assessment in the home of an older client. Which of the following, if observed by the nurse, requires immediate attention? I hear 1. Anybody have anything different? So is there everybody in agreement with 1? That is the correct answer. We want to do that, that home assessment. Why do we not want those unsecured rugs? All risk. And our patients with dementia and Alzheimer's, their mobility starts declining as well. The key word here is immediate. The rest of these we probably want to do. I'm really glad they have a pre-filled medication cassette. We need to talk to them about smoke detectors and making sure that hallways are clear. This question, the visiting nurse observes that the older male client is confined by his daughter-in-law to his room. When the nurse suggests that he walk to the den and join the family, he says, "I'm in everyone's way. My daughter-in-law needs me to stay here." So what is the most important action for the nurse to take? Okay, I hear 4. What else? Anybody else have anything else? What are you going to be concerned about with this patient? Elder abuse. So we might have to do a little more investigation with that. But we definitely need to talk to the patient and the daughter-in-law about other resources. Maybe respite care and a senior citizen center, something that the patient can go to. So this question, an older adult is accompanied by family members and being admitted to a long-term care facility with symptoms of dementia. During the admission procedure, the initial assessment by the nurse most helpful to this client is which one? I hear 2, 4. Okay, so why did you pick 2? What's your rationale?
You're taking them out of their routine, so they're gonna be anxious.
Okay, so we're taking them out of their regular routine. They're gonna feel a little anxious, a little frightened. We need to get them familiar with the environment. Why did you pick 4? Okay, so at some point we do want to do that. We want to introduce them. But what happens if we bring in too many people at one time? Then they're overwhelmed. If so, the best answer is number 2. We want to get them familiar with the environment. We want them to make comfortable with us because we're the nurse that's caring for them at the moment.
Would you call it a hospital though?
No, I don't know why they did that. Yeah, yeah. Hospital, long-term care facility. I'll go in and change those. So if you're, whatever you're introducing the patient to, we want to help relieve their anxiety and get them comfortable with their environment, make them feel secure, and decrease their feelings of stress. So things that you need to think about, like with Butch, our dementia patient, he's got declining mental status. And so the things that we're looking at is his past history, his dementia diagnosis. He's been talking to, he says he's seen his friend Roger that he served in the Navy with, but the man died 10 years ago. So we're concerned that he's having these past memories that seem real, and his wife is concerned. When we look at his mental status examination, what is in his, it's like patient care begins and then mental status examination. Is there anything in there that makes you concerned about or you feel like needs to be a priority in your plan of care to help Butch? So what about his appearance in that mental status examination? Is there anything in there that you need to be concerned of? And
You're in pants, incontinent.
yeah, he's incontinent. So we probably need to get him into something dry. What about his motor behavior? What do you need to watch with that? Do what? The motor behavior.
All this.
Yeah, he is a fall risk. So we need to make sure probably that he has good shoes on when he's up walking, and that there's nothing that he can shuffle over and fall on. He seems to be pleasant, except for when he talks about Pineville Estates, and then he gets really agitated. Is that probably a normal occurrence with people who are admitted with dementia?
Yeah.
Yeah, especially if we're taking them out of their home environment and they feel like they're losing their independence. He gets anxious and angry. So we might have to do some therapeutic communication. And do you think this might be, when this happens, is it make his wife anxious too? Probably. He still makes himself understood and he's coherent in conversation. But he is bound and determined he is not going to stay at Pineville Estates. And he doesn't think that anybody can help him. So we need to look at what's going on with him. He's alert and oriented to person and place, but he's not oriented to time or purpose. He believes it's 2017. He knows it's spring. But he has some short-term memory impaired. He doesn't remember that he had lunch. And while he's there, he sometimes forgets that his wife visits, and that's very common. You haven't been here in months. So think about things that might be important. We're concerned about his appearance. We're concerned about his incontinence. We're concerned about his ambulation. And then we need to do something to help with his agitation. And then his visual hallucinations of his dead friend. So let's go on over. We're going to look at the lab results because I think that he has, if we look at his UA, urinalysis, he has a UTI. So what might that be causing him? I think he has a UTI. That increased agitation, so we need to treat that, and that might help him become calmer, right? And then we need to monitor for other signs of infection. So let's go to part 2 when we're putting it all together, and we're looking at clinical reasoning. So patient problem, his dementia is worsening, and he's starting to have visual hallucinations and agitation. So what are some things that we can do to help that? We need to help him with hygiene. We need to make sure that his skin integrity stays intact. We need to make sure he's safe. We need to make sure that his UTI is treated appropriately. We need to keep assessing his mental cognition status. And we need to watch for underlying depression. The doctor has ordered medication. That enhances cognition and lessens the severity of dementia. It's the donepezil. And he's also ordered trazodone at bedtime. Now, here's the thing about sleeping pills in our patients with dementia or Alzheimer's. This could actually make them worse. So we need to monitor that. Tylenol for pain. And then make sure we're giving a good emotional support to him and his family. And with him, with his diabetes, we need to make sure his glucose is under control. We might want to do some orientation, reality orientation. And make sure that we introduce ourselves every time that we work with him, because he may not remember who we are. We need to provide that basic care and comfort. Make sure he feels safe and secure. Make sure we're providing emotional support for him. And maybe provide hope. Because while our patients feel hope, they continue to thrive. We need to be engaged with him. We need to be present. And then we need to figure out ways to reduce his care-resistant behaviors. Provide him options. It's really nice when our facilities provide a menu And they can, if they're alert enough, they can choose what they want to eat. Or they can choose, do you want to take a nap or do you want to watch TV this afternoon? And make sure that we're providing touch, not necessarily healing touch, just touching them. Before COVID, in the long-term care facilities, you could probably hug your residents. But if you just lay your hand on them or let them know that you're there and that you care, I think that's so big. We need to try to engage them and help them develop trust, and we need to develop rapport with them, be respectful, be genuine, and have empathy for them and for their caregiver. So think about, you're going to do, you're going to think about what you need to do with your head to toe assessment, what you need to assess for your patient that has dementia and Alzheimer's, like skin integrity, wounds, lesions, those kind of things. You want to think about doing that, some kind of a cognition mini mental exam to see where they're at. We want to make sure that if medication is ordered, that we're providing that and that it's appropriate for the patient. We also want to make sure that they're safe. Safety is priority. And that they feel, he may not be happy that he's in Pineville Estates, but hopefully he can become content. And that he feels safe with his caregivers and that he feels cared for. We need to provide emotional support for families. And we need to think about educating families about therapeutic communication so that the patient and the family doesn't get frustrated with each other because they don't understand each other. Does that kind of help with what you're looking for? So look for nursing care, nursing interventions, what we can do to help decrease their level of impaired cognition. Think about the stages of Alzheimer's. I'll put the medications, I'll put that on resources. Do you want me to put the stages of Alzheimer's disease in a Word document under resources? Okay, I will do that also, because I know there's one question about, there might be a couple of questions about that.
Christy,
Yeah.
so in my year or so for cognition, there was like the prep you, and then there's like the assignment that was in there for the concept map.
Yeah.
You're doing the concept map and we're doing this dementia patient?
No, the dementia patient, no, that was just for us to do in class. That's
Okay.
not an assignment.
Okay.
Let me pull up the assignment real quick.
Christy, your prep you post class that's due on the 8th, is that the Alzheimer's disease one? I assume.
PrepU, yeah, the PrepU is the Alzheimer's. Let me do this. Let me pull up this, the PEP assignment.
It says it opens on Thursday the 8th at 11 and closes
Oh.
Thursday the 8th at 12.
Is that in PrepU?
Yeah.
I'll just change that. Thank you for letting me know that. Okay, here is the assignment. And here's the deal. I put in the assignment, in the links, I put this sheet. I've also put the nursing process concept map that we did at the beginning of the year to give you an idea of how to do a concept map. I've also put a blank concept map template that you could use, but you do not have to do this in a concept map. You can just go through and do it linear and answer the questions. So know why it won't let me scroll. Now I know that I can scroll with that. Anyway, okay. You go through, like the second one, it says to define the following terms. And so you'll go through and define those terms. And you could just type this out on this document. All right, I gotta stop sharing. I don't know why it's not letting me. And then there's other questions. That talk about, all right, what is going on here? So then there's other questions. It's going to ask about developing a plan of care. And you don't have to do that in a concept map. You can do that linear. I don't know, my computer is having issues here. So you can type out your plan of care. You don't have to do it in a concept map. Do it however you're comfortable doing it. I have students do it, but here's the thing, if you do it in a concept map and you hand write it, it has to be legible to where I can read it. Otherwise, it doesn't count. So just pull up that document and type in your answers, and then you can upload it, and that will count.
Who is this plan of care?
It's you can use Butch. It's just a basic plan of care for someone with cognitive impairment. I can't get this silly thing to scroll.
On those definitions, do you want us to like cite the definition, or we?
Christy, are you wanting us to turn in the post-class prep view? Or is it one of those that don't have to be turned in?
What's that?
The post-class prep view, does it have to be turned in or not be turned in? Because it,
The post-class prep view does not have to be turned in. I'll go to the grade book.
Okay.
I'm sorry, what was your question?
I was just wondering on those definitions.
Yes, you should cite your references, and you can use the textbook. So make sure you use APA references. Use the Purdue OWL. That is the best place to go for APA, I feel. What other questions? If you could, do you have the signature sheets?
They're in here.
Yeah, I'll come pick them up in your other room. Any other questions before I end? There is a study guide on resources for cognition for the test.